Hello, and welcome to today's webinar about the Get Ahead of Stroke campaign and pre-hospital stroke systems of care. My name is Kate Fink, and I'll be today's moderator. This webinar is hosted by the National Association of Emergency Medical Technicians, NAEMT, and supported by an educational grant from Medtronic. Before we begin, I just wanted to go over a few housekeeping notes. Please note that we will be recording today's webinar for future viewing on the NAEMT website, and you'll also receive an email with the recording within 48 hours. If time allows, we'll have a brief question and answer period at the end of today's webinar, so please send your questions throughout the webinar, either by using the chat box or the questions box on the right side of your screen. All right, so to get things started, we had a couple polls so we can better understand how you currently work with stroke patients. So poll number 1 is, how often do you transport stroke patients to hospitals? And the poll is going to execute. There you go. You'll see the poll open period in the poll section of the webinar. Oh, I see some responses coming in. We'll give it, we have about half of you folks have voted, so we'll give it a couple more seconds. Okay, so if you want to close the poll. So to answer the question, how often do you transport stroke patients to the hospitals? We see that most of the participants said 1 or 2 times per week, followed by 1 or 2 times per month, and then only a few times per year. So that's good to know. All right, let's do our second poll. Poll number 2. Do you assess stroke severity before patient transport? So we'll go ahead and launch the poll, and then please make your selection. Great. Yeah, we have about 70% voting. Excellent. Give it another second. All right, let's close the poll. So yeah, this is great. So a majority of folks are already assessing stroke severity before transport, 74%, and then 17% sometimes, and then 9% no. But no matter kind of how you answer the poll, I think you'll walk away with today's webinar with some great information about assessing stroke severity. So without further ado, let's kick off today's webinar. I'd like to introduce our 3 speakers today, beginning with Dr. Adam Arthur. Dr. Adam Arthur is a neurointerventionalist at SEMS Murphy in Memphis, Tennessee. He is also the president of the Society of Neurointerventional Surgery. Dr. Arthur is one of the few neurosurgeons in the country to develop a busy practice in both open cerebrovascular surgery and endovascular neurosurgery. He is actively engaged in several areas of research to improve the treatment of patients with cerebrovascular diseases such as aneurysm and stroke. Our next speaker will be Dr. Joseph Hawley. Dr. Hawley is the medical director for all 911 EMS in Memphis and Shelby counties in Tennessee, as well as the medical director of EMS for the state of Tennessee. He is also medical director of Tennessee Task Force 1, the FEMA Urban Search and Rescue Team. He provides patient care in the emergency department at Baptist Memorial Hospital, Kohlerville. And our final speaker will be Mr. Scott McDaniel. Mr. Scott McDaniel has been a paramedic for 23 years and is currently a flight paramedic practicing in Illinois. In 2016, he experienced a severe ischemic elbow stroke and was treated at St. Anthony's Medical Center in St. Louis, Missouri. I'm now pleased to hand things over to Dr. Arthur.
Thanks, Kate. Well, as many of you know, stroke's a big deal in the United States. It's the leading cause of long-term disability and one of the leading causes of death. More than 800,000 people at this point in the U.S. have a stroke every year, and the vast majority of strokes are related to blood clots or ischemia, a lack of oxygen and blood flow getting to an area of the brain. Interestingly, in surveys, stroke and loss of neurologic function is the greatest fear of Americans. And one of the sad facts about stroke is that it maims or disables many more people than it kills. Next slide. So this is one of my favorite maps. This is from the Centers for Disease Control, and it shows death by stroke in the United States. One of the reasons I like it is that I live here in Memphis, and it looks like somebody set off a nuclear bomb in Memphis. and that's why we call the stroke belt the middle of the United States. Next slide. So you can tell when someone's having a stroke by looking at their exam, and that's what many of you do in the field. So depending on where the stroke is, you'll get different symptoms. But this slide lists some of the most common symptoms from blockages in the left hemisphere, the right hemisphere, or the posterior circulation, the cerebellum and brainstem. Next slide. And then hemorrhagic stroke, which also requires emergent treatment, can often present with sudden, terrible, worst headache of their life, neck pain, light intolerance, nausea, vomiting, and a rapid decrease in consciousness. And these patients need treatment at a stroke intervention center often also. Next slide. As far as risk factors for stroke, you can see why here in the Mid-South we have so much of it. Nicotine, high blood pressure, diabetes, atrial fibrillation, physical inactivity, poor diet are all modifiable risk factors, but we know that certain races and then, of course, gender and age have a effect on your stroke risk too. Next slide. And then there are things that can look like stroke and get EMTs and the whole health system worried that there's a stroke, and then it turns out not to be. Some of the most common things we see are intoxication, hypoglycemia, a tumor in the brain, seizures, certain kinds of migraine, or functional hemiparesis. And it can be hard for anybody with the most skilled training to sort out stroke mimics at times, which is one of the reasons why imaging is so important. All right, well, I'm now going to turn this over to Joe Holly, who's going to take us through some more slides.
Well, thank you, Adam. I appreciate it. So one of the challenges that we have in EMS is addressed by this quick poll here. So let's open this up and get some feedback from our audience on what kind of stroke scale we're using out there to assess these patients. So we'll give this just a minute or so to allow attendees to respond. All right, so I think we've got pretty good response there. Kate, can you tell us what the results of that were? So, Kate, are you able to give us the results of that poll?
Yes. So we have 40% responded with fast ed. We have 23% CPSS, 14% race, and then 19% using another stroke scale. So fast ed seemed to be the most common.
So fantastic. So we have actually quite a bit of variety of scales in use to assess stroke patients and help us to direct them to the appropriate level of care. And I think to some extent this is one of the real issues that we face in EMS is that the reason that there are lots of different scales out there is that none of them are perfect. And the primary reason for the use of scaling systems like this is to initially to help us identify patients that may be a stroke and try to eliminate some of the stroke mimics that Dr. Arthur talked about, but also more importantly to help us identify certain subsets of patients that may benefit from different therapies, primarily interventional therapies. And that's why we're using these scales in general. So let's look at a couple of these in a bit more detail if we could. On the next slide here we have an example of the Cincinnati Pre-Hospital Stroke Severity Scale, which has been around for quite a while. And it's got the advantage of having a fairly simple binary sort of functionality to it, meaning that with the three major categories here, facial droop, arm drift, and the patient's ability to speak, it's either normal or it's not normal. And the scaling system is simply based on a yes or no, or normal or not normal response. So it has the ability to be a fairly simple scale to administer, and one that's pretty easy to interpret the patient response and how you should code that out. So let's take a look at another one of these. And that's this Los Angeles pre-hospital stroke screening tool. And as you can see, it's a bit more detailed in what it attempts to ascertain on the patient. So the challenge here is we get more detailed information, which helps us, we hope, to more precisely risk stratify patients and more precisely determine which patients may benefit from which particular interventional therapy. But it is quite a bit more extensive. It's a little bit harder to simply remember off the top of your head, and may require the EMS provider to pull out a reference tool to be able to ensure that we're looking at the right things and that we are coding those things properly. So let's move on to the next slide now. This is an attempt at a validation on really looking at pre-hospital stroke scales and their ability to primarily tease out a group of patients that have large vessel occlusion. And the reason that this is important, and we want to identify these patients in the pre-hospital setting, is that these are particularly devastating strokes, and these are also strokes that whose patients benefit the most from interventional therapy, as opposed to use of clot busting agents and that sort of stuff. These folks really need interventional neurosurgical procedures in order to directly remove the clot and restore flow to that part of the brain. Their outcomes tend to be much better, and their residual from their stroke tends to be much less. So it's extremely important that we work very diligently to try to identify patients that may have large vessel occlusion, and to ensure that we are transporting those patients to facilities that can provide the highest level of stroke care necessary to significantly impact their outcomes down the road. So next slide here, please. So this stroke scale here, as you can see, literally is, again, quite a bit more detailed. This is the race scale. And as you can see, it not only has a greater number of areas that it assesses, including agnosia and arm function, leg function, etc., but it now is much more detailed in the scoring system. So it's not just yes or no, but it's yes, some, more, or a lot to some extent, and those are scored accordingly, so that the score that we're left with is a bit more predictive of patients that have signs and symptoms that are more commonly seen with large vessel occlusion, and hopefully allow us to better stratify our patient population, tease out that population that we particularly are interested in ensuring gets to an interventional facility, and allow us to identify those patients earlier. Next slide, please. So part of what is also important, once we've identified the patients that we really think have any kind of stroke, but particularly LVO strokes, again, that require a bit of a different approach, is transmitting that information to the emergency department so that we can ensure that the ED and the subsequent care is prepped and ready to go to shorten the time to intervention. Obviously, as with all ischemic conditions, STEMI, et cetera, we want to make certain that we are greasing those wheels as much as we can to ensure final therapy gets done as quickly as possible. So in addition to sort of our standard report, it's very important here to make certain that the receiving hospital understands sort of a brief history of what's been going on related to the patient's neurological symptoms. Are there other confounding factors that may play into the treatment of that patient? For example, are they on blood thinners already? Do they have atrial fibrillation? Have they had a stroke and then a fall and they have a head injury on top of that? And then all the things that EMS has done in response to whatever other conditions they've noted, including medications and oxygen, things like that. And then not only our time of arrival at that receiving facility, but absolutely most importantly, when did the patient's symptomatology start? And I think we have to be very careful here that we don't say 30 minutes prior to the phone call. That number doesn't tend to be very beneficial. If we can utilize more objective time parameters, I think there's great value in that. We can say the patient's symptoms started at 2:30 p.m. today. That number doesn't change. 30 minutes prior to our arrival tends to sort of change because nobody knows exactly when the arrival was or which arrival, et cetera. So we want to be careful that we're trying to utilize numbers that are easy to understand and are not referenced to the timeline of patient care, but are referenced to something outside of that that doesn't change and everybody can understand. At noon today, or when the X and Show television show came on, or something along those lines, to help make those objective timelines much more clear. Next slide, please. So part of our management of these stroke patients, you guys are already quite familiar with. It's always the basics, as with everything, of course, to assess the ABCs as you would expect. Certainly we want to make certain as best we can that we're not being fooled by one of the stroke mimics. It's certainly not uncommon that these patients have multiple comorbidities, diabetes especially, so an assessment of their blood glucose level is vitally important, as is all of their vital signs. That medication history becomes very important. Not only does it tell us about their cardiac history and whether or not they may be on blood thinners already, et cetera, but are they on herbal supplements that may influence the effectiveness of other drugs that they're on, et cetera. 12-lead EKG is vitally important in these patients. Atrial fibrillation is a common condition that we see in many of these patients and may well be the cause of their stroke. So we want to know whether or not that is present early on. Ideally, we want to get IV access on these patients. That's a time-saving function for the emergency department. It also helps in the administration of medications, et cetera, particularly blood thinners and thrombolytic agents should they be necessary. So that's a big time saver for ED care as well. Next slide, please. One of the things that we want to assess is, although not every patient is going to be a candidate for thrombolytic therapy, and there are many contraindications that we can assess in the pre-hospital world to help move things along more quickly again in the ED. And that's obviously any sign that they have had recent surgery of some sort. They've had some sort of recent injury of some kind. They have an active source of internal bleedings from ulcer disease or something along those lines. Or this is a patient who's got a condition that affects their ability to clot already. The last thing we would want to do, obviously, is make that much worse. It's obviously also not uncommon for many of these patients to have pretty severe hypertension. Management of hypertension in these conditions is a little bit of a black art, I think. We're not exactly certain the best thing to do with those. In general, our approach to them is really to only treat extremes of blood pressure and only treat those extremes of blood pressure a little bit. In other words, we don't want to take a patient with severe hypertension and drop their blood pressure to normal. They are already auto-equilibrated to the higher pressures, and they're requiring that for perfusion of their brain. And so at most, we might want to lower a severely hypertensive patient's blood pressure by maybe 15% or so. That's a bit of a double-edged sword, and we have to be careful that we don't push that too far. So let me turn this back over now to Dr. Arthur for sort of the next phase of care of these patients.
Thanks, Joe. So yeah, we've seen our system get very focused on giving TPA, but the problem is if there's a blood clot or blockage in a large vessel in the brain, the TPA is very unlikely to work. So this is a reference from a paper that shows the angio where you have a blocked middle cerebral artery on our left of the screen, a basilar in the middle, and internal carotid on the right. And the evidence we have is that with TPA, you're looking at anywhere from less than 10% to maybe as high for a distal MCA of 40% chance that the TPA is going to do something good for the patient in these worse strokes where they'll have a high reading on any of the scales that Joe mentioned. Next slide. So what they need is a thrombectomy. Thrombectomy is a procedure that my group did at the two main centers in Memphis over 300 times last year. The numbers are going up and up and up, and the reason is that we're seeing that this is literally maybe the most important procedure that can be done in a hospital if you're measuring quality years of life restored to patients. What we can do is go in the groin artery, or sometimes more now the wrist artery, and either put a suction catheter or a stent up into that blocked artery in the head and pull the clot out. Next slide. The issue is that depending on the circulation in that person's brain, and we all have different circulation just like we all have different fingerprints, you've got brain cells that are dying. And unlike skin or muscle or bone, we can't regenerate those brain cells. And so they're dying at a rate on the order of 1,900,000 brain cells every minute. And so this is why it's so critical for these patients with blockages of large arteries in the brain, ELVO, emergency large vessel occlusions, that we not waste any time at all. We have to get them into a center where the team are used to doing thrombectomies and do them well and quickly. This is a paper from Jeff Saver in California where he looks at average number of neurons lost per minute. So you're losing 12 kilometers of fiber every minute. That's a pretty fast rate. Next slide. And then the issue of transfers. So as the medical professionals in the field, when you see these patients, different EMS systems are going to sort of route patients in different ways. But there's no question, and I think Joe and Scott would agree with this, we've got to get better at this. And what happens if you have a patient who needs a thrombectomy and you take them somewhere where the thrombectomy can't be done in a timely fashion is that the giving of report and transfer the patient first to one center and then another center adds so much time that by and large these transfer patients are missing their window. And by the time they get to a place where they can get the thrombectomy they need, the brain tissue is dead, and it's too late. You can't open the tap to that dead brain tissue and expect anything good to happen. Next slide. And so this is one of the reasons why we're all over the United States exploring how to organize better and identify these patients quickly at every stage, and that means public education and awareness, speed of emergency medicine response, bypass to a center that can do this and do it well and do it quickly to try and increase these patients' life expectancy by an average of 5 years, give them twice the chance of being independent 90 days after a stroke, and gain literally a week of healthy life on average for every minute that we save in getting them to the right place. Next slide. So ideally, and there's an article in the Washington Post from this weekend about this, these ELVO patients, patients who have large vessel occlusion or actually patients who've got a significant hemorrhage, would all go to a stroke center that has everything there. And probably if there's a stroke center like that within even as much as an hour or two, that's where they should go. But if not, then a lower level of care where they could potentially get TPA or have diagnostic studies done is obviously the best thing. And you guys in the field are having to make these calls all the time. Next slide. So one of the things we're faced with as a group of people who want to help patients is this horrifying fact that less than 1 in 10 of patients who need these procedures get it. And that here in 2019, we know that we're all just kind of behind in terms of developing the best practices for getting patients to where they need to go. Next slide. And so there are a lot of different approaches to this. There are mobile stroke systems. There are groups of individuals that are going to different hospitals. But what we need to do is to update our protocols so that we get these patients to the right place, educate the public, educate EMS, doctors, and nurses so that we can take care of these patients in a more timely fashion. Next slide. And I think trauma is a really good comparison. Most EMS professionals are very familiar with trauma. I mean, if you respond to a high mechanism motor vehicle accident or a penetrating injury like a gunshot wound, it's very clear. We've got a golden hour. We go to a level 1 trauma center. You don't want to take them to somewhere where they then have to be transferred to a trauma center. But the problem is stroke is even more time sensitive than these trauma patients, but often it's not as easy to recognize the definitive study as a CAT scan, which is hard to do in the field. So we have to get to a situation where we're doing better for stroke patients and we're treating them as urgent or more urgent than the worst trauma patients, because in terms of the threat to their ability, they are in that situation. So here's the typical protocol for a trauma patient. Next slide. And then here's what we're talking about for a stroke patient. The triage, transport, and treatment. And to the extent that we can, for ELVO patients and for hemorrhagic stroke patients, eliminating that red box where they have to go to one hospital only to be sent to another hospital is critically important to save life and function. Next slide. Okay, so I think I'm turning it over to Scott here. Scott?
Hello, Scott. In 2016, like Kate said, I had a large vein occlusion at work while I was on the ambulance, and they took me to a comprehensive stroke center. It was in my middle cerebral artery. And I went to interventional thrombolectomy, removed the stroke, and I walked out 13 days later with very little rehab. And if I would have went to a normal, a non-hospitalist, non-thrombolectomy, I would probably be paralyzed. But now I'm on the helicopter working every day. So what we have is resources for EMS. Next slide.
So, Scott, this is Kate. We were getting a little bit of an echo on your audio. I was wondering if you could maybe, or just mute your computer speakers, maybe.
How's that? Is that better?
Yeah, thank you.
Okay, so in EMS, we can't remember anything hardly, so we need to, most of the stroke scales we do are Cincinnati stroke scale, but with our stroke app, through the Get Ahead of Stroke, we have several different apps and stroke scales on there, so we can use those. Next slide. We have the Los Angeles Motor Scale, the Rapid Arterial Occlusion Race, and the Cincinnati Pre-Hospital Stroke Scale, and the Stroke Scale, the Cincinnati Pre-Hospital Stroke Severity Scale, and the FastEd VAN. All these can be done by your app on your phone. It doesn't take that long to pull up that app and find out if these patients are having a large vessel occlusion. Next slide. And then based on your results, you can text these to the charge RN at the receiving facility if it's a comprehensive stroke center, or email the results to them also. What this will do, this will alert that facility, hey, we have a stroke coming in and we can get that patient there. As you can see through here, it'll go through every step, like this is the Los Angeles one, where you have facial droop with a smile, lift up both arms in front of you, grip strength, and then finish. Once you're finished, you send those results off. But what we have to do in EMS, you can hit the next slide, please. We need to identify our comprehensive stroke centers in our respective areas. Here in St. Louis, we have, I believe, 5 comprehensive stroke centers that we can go to. I'm on the Illinois side, so we might have to take a little bit of extra time, which Dr. Arthur talked about. It might take us an additional 20 minutes to get a patient to these stroke centers, but versus taking them to a non-stroke center where they can only treat with TPA, we might waste. I've seen patients sit there 2 hours with a LVO, and when they could have been wasted 20 more minutes, take them to a comprehensive stroke center and get treated the right way. And next slide, please. This shows where you can get on the Google Play Store and the Apple Play Store. These are additional resources for the Get Ahead of Stroke on our website, and you can post these in your service and resource hospitals if you have those. Next slide. And like I said, we can download these from the I would recommend these. I have these on my phone that I use on the helicopter and when I work ground also. And tell your fellow workers about it. And you have to do your patient justice. We're here to help our patients, not injure them anymore. Go ahead to the next one. And there we go. Kate, you can take it over for questions.
Yeah, thank you so much, Scott. We really appreciate you sharing your story about stroke. It's really inspiring to hear. So definitely, we've gotten questions have been coming in throughout the presentations, but continue to send your questions either to the chat box or to the questions box, and we'll start a question and answer period. So I'll start off with the first one, and I think this would be for Dr. Holly. The question is it a good practice to do the CPSS scale, and if positive, then do the race scale? So doing the two scales.
That's a great question, and I'm not sure that I know the definitive answer to that. There has not been a lot of data yet looking at sort of the use of multiple scales. I think that it would make sense that the more information you can gather, perhaps the better we can direct our patients to the right spot. But I think part of the challenge that we face is the issue is not all just in the scales. It also has to do with the actual presentation of the patient. So the ability to identify a patient by clinical exam alone is a little challenging, and it's easy for us to be fooled. It requires us to assess those patients very carefully, and I think as time goes by, we'll see continued improvement in our scaling systems and our rating systems that allow us to be a bit more precise. But it is a fairly imprecise science at the moment. And I think one approach for many EMS services to that issue is even patients that are not scoring terribly high for an LVO get get moved toward comprehensive centers anyway, with the idea that we're going to over triage to a more comprehensive center with more capabilities, even though every patient may not need all of that. It's a bit of a safety net approach in that we can have the few that might slip through the screening tool at the moment might end up at a higher level center anyway.
Great, thank you. And I think our next question is for Dr. Arthur. This one is, how can I find out where thrombectomy is available in my area? Like what hospital I need to go to for thrombectomy? Oh, you might be on mute, Dr. Arthur. Or Dr. Holly or Scott, do you want to take this one on?
So you can, I mean, I looked up through, I just honestly Googled, my favorite thing to do. My kids say you can't Google everything, Dad, but I tell them you can. I just Googled, you know, comprehensive stroke centers in St. Louis area, and then they all popped up. And I don't know if that goes to the Missouri, you know, Department of Health or whatever, but look for your local, you know, try first through your local Department of Health, if that's Illinois, Indiana, whatever state you're sitting in, and that they should be able to help you identify your level comprehensive stroke centers to find out where the thrombolectomies can be performed.
And this is Joe Holly. I agree completely. There are a lot of efforts underway at the state and regional level for the EMS administration, you know, for your state to be involved in helping to identify hospitals and their capabilities. Certainly, SNIS is a valuable resource for those stroke-capable hospitals as well. In many cases, the websites for the hospitals in your area will post information about that. And I am all about just showing up there and asking somebody whether or not they can do the things that you need for your patients to find out from them directly.
So this is Adam Arthur. Sorry, I couldn't answer initially because I was muted. But on the SNIS website, which is snisonline.org, there's a doctor finder under the patient center. And I guess one other thing to mention is, as I said earlier, this is all work in progress. And so there's significant controversy right now about what you know, a properly staffed stroke center is. Is it just anyone who can put a catheter in a vessel? Maybe they don't have formal training in getting into the brain, or maybe they don't spend a lot of time in the brain, or do you want, you know, dedicated neurointerventionalists that have that training and that do it all the time? I will say that there's good evidence specifically for mechanical thrombectomy, as well as for pretty much every surgical procedure that we've studied, that both expertise and practice matter, which just kind of makes sense. So if it's my mom that you're carrying, I would want you to go to a center that's staffed 24/7 with neurointerventionalists who don't just do a thrombectomy once a month, but they've been, you know, in the patient's middle cerebral artery, you know, 4 times already this week for strokes, for aneurysms, for other things. But this is a you know, a contentious issue that is being grappled with all over the place because not every hospital can be a fully trained level 1 stroke center, but pretty much every hospital would kind of like to be. And so there's questions about you know, what constitutes a best practice at a stroke center. But if you go to the Find a Doctor section under the snisonline.org webpage, that'll enable you to look, you know, at your area where the neurointerventionalists are practicing, and that's at least one resource you can use.
Thank you. Great. So I think our next question could be for all 3 panelists. The question is, does air transport pose additional risk to stroke patients?
That's a great question. Adam Arthur here. Not as long as we don't have a crash or anything. Air transport's very useful in markets where you can do it and the weather allows, but the changes in barometric pressure have never been shown to have any additional major risk for stroke patients that I know of. I don't know, Scott or Joe, if you want to chime in.
No, Scott, we don't really have any, we don't watch our altitude or anything, but we only fly at 3,000 feet possibly. But we don't have any, we take stat strokes quite a bit on the air.
Got one this morning already.
Yeah.
And this is Joe Hawley. You know, our service is very much the same. I don't know that that plays a terribly significant role, as Dr. Arthur said. I would think that the differences are probably related to much broader changes in altitude and or pressures. So from sea level to 30,000 feet in a non-pressurized aircraft, as opposed to the much lesser significant changes of helicopter level transport.
Thank you. So yeah, next question. This could go to either anyone on the panel. How successful has the European model of mobile CT teams been, and do you think there's traction for that in the U.S.?
So I can start with that. I think you're right that in Germany, this idea of mobile stroke units where they have CTs on the ambulance started, and it's gained traction in the U.S. We have a mobile stroke unit in Memphis. We're getting ready to have another one. Cleveland Clinic was one of the first one. UT Houston in Texas. There's now at least a dozen, maybe 2 dozen there in Chicago, Long Island, everywhere. I think that there is early evidence that they can provide a significant benefit because that CAT scan really is the screening test that allows you to know whether you can give TPA or not, and TPA is more effective if it can be given very early. And then, of course, if there's a large hemorrhage or if you do a CTA, as we're doing, and you can see an elbow, you can essentially bring those patients directly into the operating room or neuroangio suite. The problem is that CAT scans are big, cumbersome, and expensive. And so it's a little bit difficult to scale that up to make it broadly available to everyone throughout the geography of the United States.
And this is Joe. I agree with everything Dr. Arthur just said. You know, our experience here has been, I think, pretty positive. The impact on patients has been pretty substantial. The challenge with it, as he mentioned, is that they are very expensive resources dedicated to a fairly small subset of our patients. So the viability of them financially is challenging, and because it is a single point resource, it is very difficult to get it from one side of the city to another in a timely fashion to maximize its benefits. So I think on the pure clinical side, they make some sense and they have some value. I think the challenges are how to operationalize that and do it in a way that is a sustainable model for your system in general.
Great, thank you. And then I think the next question, we could start with Dr. Hawley. The question is, what is the threshold systolic pressure for treatment management?
Well, so that's another very controversial question. I believe current recommendations are systolic pressures over 200 or 220, and that in those patients you want about a 15% reduction in that systolic pressure. There is a fair amount of discussion around the use of mean arterial pressure, as that's much more indicative of perfusion, pressure in the brain, et cetera. But, you know, we have to pick some numbers somewhere. I think that the overall feeling is that for pressures, systolic pressures, particularly less than 200 or diastolics less than 160, that the response is to do nothing but to monitor those patients, that pressure has been there for a while, and that those patients need that they're auto equilibrated to that much higher pressure, and that if we reduce that very far, we actually make their perfusion worse. So, Dr. Arthur, you have some additional to add on this?
Yeah, the last recommendations I said were not to treat for under 220 systolic, and I guess I'd echo what Dr. Holly is saying. My preference, since we don't know anything about these patients, they really are like trauma patients, and some of them have gotten used to very high pressures, or they're auto-pressing themselves up to try and get perfusion to the brain. So I would caution to be very light-handed in terms of trying to address hypertensive crisis in somebody who's got a clear, lateralizing stroke. I think it's probably better not to treat, or to treat very gently.
Great, thank you. And we got a question for Scott, kind of a detailed question. So it says, we are 1.5 hours away from a comprehensive stroke center. If we drive that way from the field, we are leaving community assets on the highway for over 3 hours. Would we maybe consider a tier with air ambulance instead?
Yeah, absolutely. You can start a stat stroke program and absolutely call, meet the helicopter halfway and have them continue on to the comprehensive stroke center. Absolutely, because it's just like an MI or a trauma patient. You're taking that patient to the most appropriate facility. That's our goals. Usually that's what every standard operating procedure, SOG, has in it, the most appropriate facility for that patient. So absolutely, call your helicopter in and take them if you're that far away.
Great, thank you. And then to everyone, just general thoughts. Someone mentioned that there is the Miami Emergency Neurological Deficit Exam. Have you all used that or have any thoughts on
that? This is Joe Holly. I'm familiar with it. We don't currently use it in our system. There are probably, currently to my recollection, about 15 different scales out there that are being looked at and evaluated. Again, I think it's back to what we talked about earlier. Just none of them are perfect, and none of them are specific and sensitive enough yet to allow us to settle on one single issue. So we continue to look for better ways to stratify these patients.
And just for everyone on the call, the stroke scales for EMS app is available on Android devices and on Apple devices from the App Store for free. So if you guys are interested in having that on your phone, you can have it on your phone, and it gives you a variety of different scales that you can use and can be helpful.
Great, thank you. All right, we're coming to the end of questions, but so just one of the last ones is also very specific, so I would, whoever wants to answer, jump in. So this is, our service is in a very rural area, and we cover about 2,600 square miles. Our nearest hospital is 50 to 100 miles away, depending on the place of the scene in our area. The next closest is about 90 minutes away and does not have a neurosurgeon on staff 24/7. Should we bypass the local small hospital and use light flight to the larger place?
So this is Adam Arthur. If I understood your question correctly, the larger place is 50 to 60 miles away and available by life flight. And is that right, or was it the larger hospital is 90 to 100 miles away? I'm not sure it matters. I shouldn't get into the minutia. You're probably a lot smarter about how to manage those patients than I am. I think to the extent that it's feasible, if you think someone is having a significant stroke on your evaluation, getting them to a place where they can have the intervention they need as soon as possible is the most important thing. And medical directors like Joe, Holly, and whoever it is for you out west spend a lot of time, working on trying to develop those systems. So maybe the best thing for me to do is just to say, you should talk to the people there and make sure that you guys are doing what you think is best for your patients. Joe, you want to jump in?
Yeah, I don't have a specific answer here, but I think one thing is pretty clear, and that is the use of helicopter services for these patients makes more and more sense when the helicopter is utilized in such a way as to maximize one of its primary advantages, and that is they're fast and they can cover a lot of territory in a small period of time. So I think when driving distances are long, helicopters make more sense to move those patients to appropriate centers than when transportation distances are short. The helicopter simply is not in the air long enough to take advantage of its, speed twice what an ambulance can do. So I think for rural situations, there is a greater advantage for the inclusion of a helicopter EMS component to your stroke patient management.
Great. And this is a question that kind of flips the script, so kind of moving to metropolitan and urban areas. Someone asked a question on kind of the panel's thoughts on the efficacy of mobile stroke units in metropolitan areas with short EMS transport times.
So I know in Chicago they're doing a lot of work. I think there may still be some efficacy if you're able to deliver TPA, on board. But we don't have a randomized trial to prove that yet. I can tell you that in the Cleveland metro area, I'm aware of at least one patient who got TPA 9 minutes after stroke onset because EMS was able to jump to them quickly, do the CT in the driveway, and push TPA. That's pretty impressive, and it really doesn't give that clot much chance to seize up. And of course, then you can go from TPA while you're heading to your stroke intervention center. So this is still something that's very much under study, but I'm not ready to say that in urban areas there's no role.
So I'll jump in on this too. I think this is another situation much like we were just talking about with helicopters. These are expensive, limited availability assets. It is not yet obviously clear where the biggest benefit for these units is. I certainly can understand that if you're in a large metropolitan area that has lots of comprehensive stroke centers scattered all around and your transport time for those patients is quite short, that the opportunity for a CT ambulance to have an impact is less than it would be if you had fewer stroke centers and more strokes and more territory to cover, et cetera. So I think that's part of the challenge of the utilization of this tool is what is the optimum environment for that tool to be utilized in. And that, as Dr. Arthur said, we're still kind of figuring that out. We've certainly seen some impressive results out of a relatively narrow geography in a densely populated area. Houston is a great example, as has been Memphis. And the impact has been pretty impressive on the relatively small number of patients that we've interacted with there. So I think you have to take a very long-term and large view over the cost of that asset versus the impact ultimately on the care of a patient with a terrible stroke, and how quickly you can get those patients back to normal function, and you have to figure in the cost of caring for those people long term if you don't do that, et cetera. So it's a very, very challenging problem on a very large scale that's going to take us a while to refine, I think.
Yeah.
Well, thank you so much. And I think we have a final question to wrap this up. And someone was asking what they thought, for all three panelists, what you felt like was the most effective stroke scale in the field, especially for detecting elbow.
Well, so I'll jump in on this first because there's not a right answer, I don't think. Um, the it seems to me, based on my interaction with lots of EMS services around the country, that the LAMS scale, LAMS, the RACE scale, and the CSTAT scales seem to be in the more common scales that are being utilized. I don't want that to be interpreted to mean that they are better, but I think you have to look at those scales in terms of not only how good are they at risk stratification and providing us in EMS with information that we can act on, meaning identify an LVO and get them to the right hospital, but how difficult is it to train on them? How hard are they to administer? How much time is spent? I got to go find that card that's got that on there so I can read it out exactly, because I can't remember it because it's way too long and detailed. All those things come into play on those scales. And so I think currently the three I mentioned seem to be the current sort of crowdsourced favorites because they aren't too complicated. They're pretty good at their ability to have good sensitivity and specificity. But as we've said a couple of times, none of those scales are yet perfect. And we continue to compare them to each other, looking for which one has the best all-around functionality for what we're trying to accomplish.
That's a pretty good answer. Not sure I can add much of utility to that.
Great. And Scott, did you have anything else?
No, I agree with that also. Just as long as we're doing it, going through the process step by step, and the apps will help you do that, and identifying that these patients have deficiencies and we need to get them to a stroke center. Absolutely.
So if I could jump back in for just a sec, I think Scott said something profoundly important, and that is the use of any of these scales is much better than the use of no scale. So while we don't know which one is the best, in this case, perfect may be the enemy of really good. So by all means, please be certain that you're utilizing some sort of objective scale on these patients and working hard to do this risk stratification piece. That in and of itself is of great value in patient care.
Great. Well, I think that's a great way to end things today. Thank you so much to our speakers today, Dr. Adam Arthur, Dr. Joe Holly, and Mr. Scott McDaniel. We really appreciate your time. I hope everyone enjoyed today's webinar. You'll get an email within 48 hours with the recording if you'd like to see it again. And thank you so much. Have a wonderful afternoon. Goodbye.